Hirschsprung's disease, or also called agangliosis of colon, or called aganglionic megacolon. The incidence of Hirschsprung disease, usually Hirschsprung disease affect 1 in each 5,000 live births. Usually males are affected 4 times more than females, but usually Hirschsprung disease affect rectum and sigmoid colon. If there is a long segment more than the sigmoid colon, in this case, in long segment affection, the gender ratio is 1:1, equal in male and female. Hirschsprung disease is familial in 10% of cases and associated with Down's syndrome in 10% of cases. What is the etiology of Hirschsprung disease? The etiology of Hirschsprung disease is not exactly and clearly known, but it may be familial in 10% of cases, and it is usually associated with mutation in RET gene. And etiologically, this mutation in RET gene leading to disturbance in the migration of parasympathetic ganglionic nerve cells. What is this? During intrauterine fetal life, there is a structure called neural crest. From the neural crest migrate parasympathetic ganglionic nerve cells in the wall of the gut, from mouth to anus. The parasympathetic ganglionic cells reaches the rectum and the anal canal by the 12th week of gestation. Arrest of migration of ganglion cells in the colon leading to aganglionic bowel segment. Therefore, the etiology is genetic mutation, and this genetic mutation interfere with normal migration of parasympathetic ganglionic nerve cells, which are derived from the neural crest, and the arrest of this migration to the rectum, anal canal, or sigmoid colon, leading to a bowel segment without these ganglion cells, leading to a ganglionic bowel segment. Pathologically, Hirschsprung disease is congenital. Congenital absence of ganglion cells. Congenital absence of parasympathetic ganglion cells in the myenteric plexus, and this myenteric plexus is a plexus between the circular and longitudinal muscle layer of the gut. This is the thickness of the wall of the colon. Mucosa, submucosa, circular muscle layer, and outer muscle layer, longitudinal outer muscle layer. Between the longitudinal and circular muscle layer, this is the circular and this is the longitudinal, Between the two there is myenteric plexus, or also called orbix plexus, orbix plexus, or orbix plexus. This orbix plexus or orbix plexus responsible for the peristalsis in the wall of the colon. There is also parasympathetic plexus in the submucosa called Meissner's plexus. And this Meissner's plexus concerning mainly with innervation of the glands of the gut responsible for secretions of the mucosa. Therefore, there are two parasympathetic plexuses in the wall of the colon. Meissner's plexus in the submucosa and orbix or myenteric plexus in between the circular and longitudinal muscle layer. And in Hirschsprung disease, there is a ganglionic bowel segment, absence of ganglion cells. Absence of ganglion cells in the myenteric plexus usually start at the anal canal. In the anal canal and extend proximally to variable segment. The condition affecting the anal canal and extend proximally for variables distance. It may affect the rectum, or much more common is usually extend to the sigmoid colon. Rectal affection only occur in 10% of cases, but affection of anal canal, rectum, and sigmoid colon is the majority of cases. It affects about 75% of cases. Affection of all parts of colon, total a ganglionic colon. This is about 5% of cases. Due to absence of ganglion cells, there is functional obstruction. Why? Because in presence of ganglion cells in the myenteric or orbix plexus, normally there is peristalsis. Peristalsis in segment with relaxation of the distal segment. Contraction of segment and relaxation of the distal segment, leading to normal passage of feces to outside. Due to presence of a ganglionic segment, absence of ganglion cells, the affected segment is always contracted, not respond to the normal reflex. What is the normal reflex? Distension of the proximal colon, leading to contraction of the colon with relaxation of the distal segment. Therefore, there is normal reflex, distension of proximal colon, leading to relaxation of the distal colon. In Hirschsprung disease, distension of the proximal colon does not lead to relaxation of the distal ganglionic segment, which remain contracted. Sure, the feces accumulate in the normal ganglionic segment, and the normal ganglionic segment becomes dilated, as in any obstruction in surgery followed by proximal dilatation. There is transitional zone between the contracted narrow segment and the dilated segment, where as this X-ray, this is the contracted aganglionic segment, and this is a dilated proximal normal ganglionic segment. And between the narrow area and the dilated area, there is a transitional zone. This transition zone between the narrow contracted aganglionic segment and the dilated normal ganglionic segment. This is called transition zone. What's the complication? Complications of Hirschsprung disease is chronic or acute on top of chronic intestinal obstruction. Sure, chronic intestinal obstruction because of chronic constipation, and acute on top of chronic obstruction due to fecal impaction. Fecal impaction in the narrow area, leading to acute intestinal obstruction. The most dangerous complication for Hirschsprung disease is stasis in the colon with proliferation of bacteria. This leads to enterocolitis. What is the problem? Enterocolitis and severe toxicity by bacteria in the colon, leading to toxic megacolon, huge dilatation and distension of the colon. The colon becomes markedly dilated. This is called megacolon due to toxicity by bacteria. Due to severe distension, perforation of colon may occur. Also, in chronic cases, there is stasis, putrefaction, proliferation of bacteria, and chronic toxicity and chronic toxemia by this patient. Chronic toxemia in this patient leading to anemia and poor development, no growth or poor growth in this child. What's the clinical picture of Hirschsprung disease? The severity of symptoms and the age of presentation is variable according to the length of bowel affection. Usually, the condition present since birth. Less commonly, it may present in older children and rarely may present in adults. It is present since birth, but discovered in adults. The patient may present by acute intestinal obstruction since birth, or much more common, gradual development of the following symptoms. A gradual development. What is the gradual development? What is the gradual development of symptoms? First of all, no or little meconium pus in the first 48 hours after birth. The mother notice chronic constipation since birth. This is the main presentation for MCQ. For MCQ, the commonest segment affection, sigmoid colon until sigmoid colon. The commonest presentation is chronic constipation since birth. Also, the stool pus in this infant is small in caliber to pass from the narrow area, and the patient have attacks of crying, which indicate attacks of abdominal pains. Sure, one of the main manifestation in this patient is this is obstruction in the colon, which rich in bacteria and fermentation and severe peripheral abdominal distension. In advanced long-standing cases, there is repeated bile vomiting, reluctance to feed, poor growth and development, and BR examination show tight constricted anal canal, followed by dilated rectum. After you remove your finger, what is this? Passage of stool and the flatus with decompression of the distended abdomen. It is very dangerous if the patient presents by severe fever, toxemia, severe diarrhea with bleeding rectum. What is this? This is enterocolitis, which may be fatal, which may be associated with toxic megacolon and tag perforation. Differential diagnosis of this patient, other causes of intestinal obstruction in newly born. Investigations as usual, plain X-ray show dilated intestinal loops. The most important investigation is rectal biopsy, which is diagnostic, followed by the second important investigation is contrast enema. The contrast enema show three zones: the narrow contracted segment, which is the aganglionic segment, absence of ganglion cells in the narrow area, which is contracted and narrow. And proximal to this narrowing shows there is dilatation of colon, which is normal ganglionic area. In between the contracted aganglionic and the dilated ganglionic normal colon, there is transition zone. Normally, during barium enema in newly born, the rectum in newly born in enema is the most dilated segment, is the wider part of the colon. If we perform in the newly born barium enema and the proximal colon is wider than the rectum, this is suspicious for Hirschsprung disease. Delayed plain X-ray film in this patient after 48 hours. What is the finding after 24 hours? The dye is still present in the colon, and there is no excretion of the dye. And to evacuate the dye, an enema is needed, which indicate distal obstruction prevent evacuation of the dye. The main investigation in this patient is rectal biopsy. Normal biopsy, we take only mucosa, as in malignancy. But here we should intake the biopsy should take mucosa and the submucosa, and this need suction biopsy capsule. We introduce a capsule into the rectum and induce suction to suck a segment of mucosa and submucosa. This will show the aganglionic area in the mycelium plexus, which is present in submucosa. If the biopsy is doubtful, we should take full thickness biopsy from mucosa, submucosa, and the muscle layer. And this surely will show the aganglionic area in the mycelium plexus and in the orbix plexus. Rarely nowadays anal manometry is done. What is anal manometry? A balloon is inflated. A balloon is inflated inside the anal canal. Normally, if a balloon inflated in the rectum, the internal anal sphincter relax. If we inflate a balloon in the rectum and the internal anal sphincter remain contracted, this indicates Hirschsprung disease. What is treatment of Hirschsprung disease? Sure as any intestinal obstruction, resuscitation. Nothing is taken orally. Nothing is taken orally. Intravenous fluid and antibiotic is very important in enterocolitis, and the treatment of Hirschsprung disease should be surgical treatment. What is the aim of surgical treatment? The aim of surgical treatment is excision of the aganglionic bowel segment. Excision of this aganglionic area. Then pull the normal ganglionic innervated colon, pull to anastomose with the anal canal. This is called Bolsterum technique. Excision of the affected pathological aganglionic segment. Then pull the normal innervated ganglionic colon to be anastomosed with the anal canal. This is the aim. The surgical options varies according to the age of the patient and the length of the aganglionic segment and the degree of dilatation of the proximal part of the colon and the presence of enterocolitis. All these factors affect the option. If there is poor risk patient, the patient is severely anemic, and the patient have enterocolitis and poor general condition, severe anemia. In poor risk patient, it is better to perform two-stage operation. What is the two-stage operation? The first stage is proximal colostomy. The proximal bowel segment is opened on the surface. The proximal colon, normal ganglionic area is opened on the surface as a proximal colostomy. for intestinal decompression. How to know the normal ganglionic or aganglionic segment? By frozen section biopsy during operation. Biopsy at operation show normal ganglionic area, proximal, open on the surface. After few months, after improvement of the general condition of the patient, the diseased bowel segment, the aganglionic segment, is resected. Resected with the transitional zone and anastomose the normal innervated bowel distally with the anal canal. This is if poor risk patient. In good risk patient, one single stage Bolsterum operation. What is done in one stage? First of all, we introduce a large rectal tube for decompression of the colon and cleaning of the colon by repeated warm saline enema 3 times daily. This is the preoperative preparation and the colonic preparation. Large rectal tube inserted through the pathological aganglionic area. Decompress the colon, remove all the stool, and through this rectal tube, repeated irrigation 3 times daily until the colon completely free from any infection, free from any stool. Then the operation is done either nowadays usually laparoscopic or usually very common transanal, and rarely nowadays it is very common in the past by open surgery. What is actually done? There are 3 famous techniques. The first technique is called sew procedure. This is sew procedure. What is sew procedure? In this operation, the mucosa of the rectum is stripped from the underlying muscle layer. Here, this is the rectum. We remove the mucosa lining the rectum. Then the normal innervated bowel, ganglionic area, normal with ganglionic area, proved by biopsy, is brought through the rectal part, the rectal cuff. This is the rectal cuff after removal of the mucosa. We pull the normal innervated bowel through this muscle cuff to be anastomosed with the anal canal. The advantage of this operation, all the surgery just inside the lumen of the rectum and the anal canal and the bowel without any surgical interference around the rectum or the anal canal to preserve the nerve supply and the arterial supply of the pelvic organs. There is another famous operation called Swenson operation. What's Swenson operation? This idea simply excision of the aganglionic segment, excision of all rectum and sigmoid core, and the normal innervated ganglionic bowel segment is pulled to be anastomosis the anus with the anal canal just above the anal sphincter. This is called the Swenson operation. This is typically Swenson operation. The third technique is Dommel procedure. What is Dommel procedure? In this operation, we dissect a bloodless area behind the rectum, the area between the sacrum and the rectum. We dissect this area, and the normal innervated bowel is anastomosed to the rectum in the posterior surface of rectum, in this bloodless area behind the rectum. This is the normal bowel segment. Positive means positive ganglion cells in biopsy, anastomosed to the posterior aspect of the rectum, leaving the anterior structure, which containing very important nerves and vessels, free without any interference. This is called Dommel. This is Dommel, anastomosing normal bowel segment in the posterior part with the posterior part of the rectum. This is the most famous in Egypt, which is Swenson operation, and this is so operation. This V and E are silent. So this is the treatment of Hirschsprung disease, and this is another pictures for our operation. This is the patient before surgery. Normal ganglion cells, transitional zone, and this is the aganglionic segment. Swenson excision of the transitional zone and the aganglionic segment, and the anastomosis of the normal bowel. This is the normal bowel with the anal canal just above this, which is the anal sphincter. This is Swenson operation. This anastomosis inside the muscle cuff. This is so operation. This is anastomosis of the normal bowel with the posterior aspect of the rectum. This is Dommel. And finally, for fun, this is the excised bowel segment after Hirschsprung disease. This huge bowel segment, which is the aganglionic segment, in which there is no ganglion cells or parasympathetic supply. This is Hirschsprung disease. Thank you for good listening and good luck.